Good morning, everybody. You're all very welcome, and we're delighted to have so many of you here this morning. My name is Sarah Mahon, and I'm a Principal Social Worker with the National Safeguarding Office. And it's my great pleasure to chair this morning's event. I'm going to start by welcoming our speaker and our panel guests. So our speaker today is Lorna Montgomery. She's a Professor of Social Work at Queen's University. She has practiced as a social worker, including at senior and assistant principal levels in the NHS adult social care sector for 20 years. Since taking up her post in Queen's, her academic interests have focused on adult safeguarding and mental health. Within the broad area of adult safeguarding, she has led a number of regional and national research projects. Her research and publications have focused on adult safeguarding and inequality, including within institutional settings, adult safeguarding and interagency collaborations, and adult safeguarding peer research. She sits on a number of statutory committees and has been commissioned to undertake consultancy work on behalf of several organisations. And despite that, she has so kindly found time to come and present with us today, and we're really, really grateful to her. Once I have handed over to Lorna following her presentation, I will ask Amanda Casey, our Chief Social Worker, to reflect on the issues that have been raised. And then Amanda will be joined by Sarah Donnelly for panel discussion. Sarah Donnelly is Associate Professor in Social Work, Director of Global Engagement and Director of Practice Learning, School of Social Policy, Social Work and Social Justice in UCD. And again, despite all of that, the two ladies have found time to spend with us this morning. So thank you, Amanda and Sarah. Any questions that you have for Lorna or our panelists, please can you put them in the chat facility, and I will be looking through them as the morning goes on and raising as many questions with the panel as I can. It's my great pleasure now to hand over to Lorna. Thank you very much, Lorna.
Thank you. Thank you for the welcome, Sarah. I appreciate the invitation to speak with you today. I suppose I want to start by saying that I appreciate that this topic is sensitive, it's emotional and hurtful for many people. And I hope that the material that I present today will be done sensitively, but also contribute to the process of improving care for individuals who require supported accommodation. Much of what I say, I'm going to be broad just because of time. So it's really a very broad overview of systemic lessons for adult safeguarding in institutional care. So what I would hope to do in the next 45 minutes is look at definitions and prevalence. I'm not sure who the audience is, and I appreciate much of this might be familiar to you, but I think we need to start with what do we mean by institutional abuse and how common is it? And then we'll be looking at the indicators and risks of institutional abuse, and then finishing with what good practice looks like. And at the end of the presentation, I have some discussion questions, although I appreciate you may have your own. I suppose the other thing to say in starting is that what I'm doing today is broadly giving an overview of the literature, and to a large extent the literature focuses on the negative, so what has gone wrong, and I don't want to minimise the very good care that happens in many places. So, I mean, we can discuss that at the end, but just to say that there is little said in the literature about the good care, and I'm very conscious of that the focus tends to be on the negative and what can improve. In some ways, these 3 points will sum up much of what I'm going to say. Probably because of the number of scandals that we are aware of, institutional abuse has become recognised as a prevalent feature of institutional living. And that's a huge thing to say, that abuse is prevalent across most of the institutional facilities that we're aware of globally. The other thing to say is that there is, to a large extent, agreement about what good care looks like. And we're going to say a little bit more about that as we go on. However, and Joyce here is talking about institutional care for people with physical disability and mental health problems. I'm not sure if you can apply it to people with older people, but Joyce is saying that To a very large extent, even though we know what good care looks like, it tends to result, the outcome for individuals who are admitted to supported housing or individual and institutional settings, that there is a deterioration in their physical and mental health, separation from families and support networks, and reduction in their ability to live as part of a community. The other key point, I think, is that whilst guidance is available, we have standards, we have protocols, the consistent message from reports and investigations is that statutory recommendations for reform have not been effective. So I think it's what Margaret Flynn talks about, unlearned lessons. And as we go through this presentation, I think you will see that despite outcomes from inquiry reports 20, 30, 40 years ago, very similar things are coming up today. I imagine you're very familiar with the definition of organisational abuse. I'm just putting it up there. Thank you to Sarah Donnelly for sharing that. Definitions of organisational or institutional abuse vary globally, but to a very large extent, they describe mistreatment of individuals that results from systems that harm the individual or fail to protect them. Ireland uses the organisational abuse broader definition. Northern Ireland, and I'll come to that in a few minutes, talks about institutional abuse, which is a bit narrower. The research evidence would say that there are three core types of abuse: resident on resident abuse, staff on resident abuse that seems to be most prevalent, and abuse by visitors to the facility. So there's evidence and investigations around all three types of abuse. Just to share the Northern Ireland definition, which is similar, I suppose, in nature to the organisational abuse definition that you have in Ireland. Maybe what is most significantly different is that we offer a threshold. And I'm going to say a bit more about thresholds as I go on, because it's very difficult to identify what is the threshold of abuse. But in the Northern Ireland definition, they talk about threshold as a violation of dignity and human rights. Again, that's subjective and open to discussion and interpretation, but it's there very firmly in that definition. As you may know, in Northern Ireland, we're still running with a policy framework for adult safeguarding, which was developed in 2015. We do have an adult protection bill that is going through our Parliament at the moment, and it looks like it will take about one more year before that becomes actioned and activated. So what is the prevalence of abuse? Whilst I'm going to present some statistics here, I think it's worth saying that it is debated and it is very difficult to know how much abuse occurs within institutions. There's a strong sense in which a lot of abuse is underreported. So the World Health Organization have taken this on as a key feature of their policy and action in the last 10 years. They would say that in 2002, they identified mistreatment of older people within institutional settings in almost every country which adopted a model of institutional care. So that's huge. Again, back to that sense of it is a prevalent feature of institutional care. Sorry, I should have said at the beginning that much of what I'm going to say, I've tried to target to care within homes for older people, just given your current inquiry. But I have some literature which looks more broadly at institutional care for other groups of people. Jon, who is actually writing undertaking a review for the World Health Organization in 2019 said that 64, so 2/3 of staff in care homes admitting abusing residents within their care in the previous 12 months. Again, that's huge, shocking. I've gone back. I actually think I met John and went and spoke with him about it because it seemed implausible to me. But what he was describing was a review of the literature. And again, that's the figure that he has come up with. More recently, there's a study in Norway where 76% of nursing staff say that they observed at least one incident of abuse committed by another member of staff in the previous year, and 60% of staff admitted to perpetrating one incident of abuse against a resident in the last year. Again, I think those are things to talk about. To my mind, a lot of that depends on the threshold. What are we determining as abuse? Nonetheless, there are a number of, I suppose, shocking scandals about the nature of care within for example, within our residential and nursing homes. I just want to mention one recent scandal in Northern Ireland. So you may have heard of it. Dunmurray Manor was a private care home just outside Belfast, and in 2018 there was, I suppose, publicity about a high level of institutional abuse and neglect of the vulnerable patients or residents in that home, many of whom had dementia. You're welcome to look at the inquiry reports, which are actually really shocking in terms of the level of care and abuse. But I think one of the things that was very significant is that not just the level of abuse that was identified in the home, but the failure of the wider system to pick that up. So, I mean, just in terms of I don't like sensationalizing the abuse, but nonetheless, there are really graphic accounts of resident-on-resident abuse, alarming weight loss of a number of residents that was, not addressed, pressure sores, sexual assaults where female residents were afraid to leave their rooms, residents going without medication for up to 3 weeks. Key part of that was that families' complaints were not believed, that there was a system throughout the previous years of reporting concerns and that they were not picked up and addressed collectively, so that they might have been addressed as an individual concern, but nobody was looking at the big picture in terms of systemic problems. And there were inadequate safeguarding procedures and oversight. So in addition to, I'm just going to mention this very quickly, but in addition to the failures of the care provider, which was at that stage Runwood Homes, a lot of the focus was placed on those agencies that had a duty of care to monitor what was going on in private residential homes. So the Department of Health was criticised because of their failed oversight and regulation. RQIA, who are our regulatory authority, who had numerous inspections of the home, was criticised in terms of their inadequate inspection and monitoring, and the healthcare trusts that commission places was also strongly criticised for poor commissioning and placement decisions. And I mean, if you want to look at it, there are 59 recommendations across 7 relevant authorities. So many recommendations looked at what should have happened within the home, but also then within the governance and monitoring of what went on. I said at the beginning that, Margaret Flynn uses the term unlearned lessons. And I think it's really interesting to see that whilst that occurred in 2018, I have an example here of what was termed the corruption of care in a hospital for people with learning disabilities in England in 1967, maybe earlier than many people on the call were actually born. It was published in the News of the World, which was a paper, call it a paper at that stage, which is now out of circulation. But the really interesting thing is that the recommendations, actually the type and level of abuse is not dissimilar to what we saw in Winterbourne View, in Muckamore Abbey Hospital in Northern Ireland, which had a similar scandal in 2018, and in some of the other scandals that you're familiar with. And the recommendations are also not dissimilar. So things like independent inspection of what goes on in the hospital, review and revision of training and supervision of nursing staff, the improvement of physical environment, all of these were picked up in Murray Care Home as well. The encouragement of more involvement and communication between staff, patients, their relative and the public, which is a key theme in adult safeguarding today, and the development of more humane and therapeutic approaches to patients. Again, a key theme. I would say that those recommendations are found in all of the more recent inquiry reports around institutional abuse scandals across the UK and Ireland. When we think about prevalence of abuse or the nature of abuse, it's important to have a view from those people who are, I suppose, subject to abuse. And there isn't, excuse me, that much written about service user experiences. I have selected 3 across different client groups. But I've also said, you know, of central importance in exploring the extent and problem of abuse and shaping our response to it has to be engaging with service users and residents and families about their experiences. So the study in Norway that I referred to earlier, so I've just selected 3 examples. The study in Norway that I referred to earlier, a part of that study is that residents were themselves interviewed, and there was a discussion with them about their perceptions of safeguarding and abuse. And to a very large extent, residents minimised day-to-day infringements of their rights. They would have seen abuse much more around the what they would describe as real abuse, which is physical acts of violence reported in the media. So they were tolerant of a lack of dignity and human rights. In some ways had no expectation around that being abusive, but only the much more kind of dramatic violence that they could see in the media. Carr interviewed, I think, focus group discussion of individuals who were patients in mental health facilities, and really probably quite an emotive account of some of their experiences. And to a large extent, the people who were interviewed felt at risk of harm and neglect by mental health services and staff. They had a fear of risk of abuse, a fear of assault, including sexual assault and theft from staff. The third, Herbert and Hollins, this was what we call an ethnographic study. So a researcher went and lived in the institution, locked ward in a long-stay institution, and the researcher concludes that men's lives were considered to be emotionally, socially and physically deprived. Their individual identities, social identities and gender was not recognised. So I'm afraid that's a very negative account of experiences of individuals who are in receipt of services. As I said, I know that that is not everybody's experience, but those are the things that are being written about in research and in the academic publications. What I'm going to do now is just take a look at the risk factors for abuse in institutional settings. As I say, to a large extent, I've looked at care homes for older people, but I've also referred to some of the literature which is wider than that. This list is taken from, it's taken largely from inquiry reports as a result of scandals of abuse, professional guidance, and some research. None of it, I think, will surprise you. It's all probably intuitive to what you know already. Because of time, I'm just kind of going to give a broad overview. But I say, to a large extent, I think these risk factors will be familiar to you. So poor leadership is identified among nearly every inquiry that I've ever read: inadequate management, lack of clear policies, weak accountability structures. And as we saw in Dunmurry Care Home and in fact Ely Hospital in 1967, lack of regulatory oversight, infrequent inspections, inadequate enforcement of standards. In terms of, we saw this in Dunmurry, poor complaints procedures, difficult reporting systems. I think I'll say a little bit more about that later. There are some studies that asked families about their experience of reporting when they were concerned, and to a very large extent they were describing the reporting systems as complicated and not user-friendly. And again, the poor physical environment, lack of privacy, overcrowding, poor facilities. Profit-driven models. There's a really interesting paper by Hurt, which I refer to later, and it's a scoping review, but he talks about really the difficulty in organisations trying to make a profit, but also then dealing with the increased demands of what residents' care needs and how difficult that is. But again, it's seen as a risk factor that cost cutting compromises care quality and staffing levels. And then again, as you would imagine, there is a lot, perhaps most written in terms of risk factors around staffing issues. There is fairly consistent research message that gaps in staff training increase abuse. The study I mentioned there was a review, focus group discussion, I think, of staff who worked in facilities for people with mental health problems and hospitals, psychiatric hospitals. And they identified limited knowledge and understanding of service user needs. They identified difficulties in responding appropriately to those needs. They actually identified difficulties in responding appropriately to safeguarding issues, and also described a lack of effective collaboration and communication between hospital and community services. The other study I mentioned there is Redley, I think, is a psychiatrist, and he with colleagues reviewed by interviewing residents the degree to which they felt their care was personal. So this was in England around the Making Safeguarding Personal model. And his conclusion, or their conclusion, to a large extent was that individuals who were subject to abuse in community settings, that they had a higher kind of perception that their care was personal and targeted at them and for them, whereas individuals in residential accommodation to a large extent felt that their safeguarding was not personal and that it was driven by organisational requirements. Risk factors, again, if we look at staff, I do not think this is new to you, but high staff turnover, a lot of recruitment, temporary staff, disrupted care relationships, and inadequate screening. And there is a lot written about high staff stress. There is a very significant relationship in the research literature in a number of studies that associates high staff stress with controlling interactional styles with patients and residents. That's across the service user groups. The research is particularly strong in settings with people who have learning disability, but nonetheless it's more broad than that. That's a really significant point. Limited staff support stress was found to increase the use of restrictive treatment and service user risk. Marsland writes interestingly about staff stress, and he said that work-based social support, so I suppose projects, initiatives to support staff and stress management projects are helpful, but to a large extent it is the broad organisational context which is most important in contributing to staff stress. So not, I suppose, the projects and the stress management opportunities, but the broad organisational culture is of most importance. Individual resident vulnerabilities have been highlighted. The work by Hurt, which I've given you a reference to, would say that there may be some inconsistent messages around this from the research, so that some are more evidence than others, but nonetheless, to a large extent, there is agreement that these are the features of an individual that perhaps makes them more vulnerable to abuse. And again, I would say to you that's probably self-evident. So cognitive impairment, physical disability, mental health concerns, an individual who is socially isolated and has few advocates, limited external social connections, individuals for whom communication is difficult, and individuals who are put at risk because of their combination, I suppose, gender, age, race, disability. Hurt would say that staff to resident abuse is unacceptable, but still underreported. And there is some consideration about why that might be. And he points to characteristics of the dyad between those two people, that essentially it's around an imbalance in power and vulnerability. And I suppose you can see how those individual features that we've listed there would decrease someone's power and increase their vulnerability. High risk situations, you might add to those from your own experience, but the literature is describing 4 key areas: intimate care, medication administration. I'm supervising a PhD at the moment for a student that's looking at medication misuse in residential care. Nighttime hours where there's reduced supervision, and behavioural management. I'm sure you're aware of the Muckmore Abbey care home or Muckmore Abbey Hospital scandal in 2018, where the biggest failing was seen to be around restraint, use of restraint. And the majority of complaints featured or focused on restraint issues. Again, I'm not sure if this is new to you. It's probably well recognised that there are warning signs of high risk environments. Closed culture is one of those. So there is an awful lot written about the importance of external scrutiny, of having members of the public, of family visiting, freely visiting, keeping an eye on things is really, really important. Staff attitude is important. So again, the observation of a very controlling environment, institutional practices, rigid routines, and I think that picks up what is part of your organisational abuse definition. Talks about rigid routines that prioritise efficiency over person-centred care, lack of transparency with families, again picked up in the Dunmurry care home and the Muckmore Abbey scandal, and financial irregularities. When I was in practice, that's probably over 12 years ago now, if we were involved with a referral to a residential home where there was more than one resident referred, so like 2 or 3 residents, we considered that a systemic issue and looked at the routines and practices within the whole home rather than just seeing it as an individual problem. There are lots of resources that help to identify risk. I've just picked up one of those, which is the NICE, National Institute for Clinical Excellence guidance on indicators of organizational abuse and neglect. And it gives a bit of a flow chart. I think it's helpful. It really sums up some of the things that I've said and gives a bit of a flow chart around indicators that you could consider abuse or neglect. So it talks a little bit about threshold, because I know threshold is very difficult, and then indicators that you should suspect abuse or neglect and what to do about it. So I think that's a very helpful resource. Excuse me. So much is written about what goes on within the care home or institution. But I want to draw attention now just very briefly to the kind of wider, I suppose, cultural issues that impact individuals' risk within residential care. Thinking about older people, but there's lots of evidence of this around other people with disabilities, is that the whole culture of ageism is significant. I could say a lot about that, but I'm just using one example here. I don't know if this example is familiar to you, but in, goodness, what was the date? 1998, so a long time ago. An 81-year-old lady called Kathleen Grundy was found dead at her home in England. Her GP was Dr. Shipman, and he recorded her death as old age. I think her daughter was a lawyer, and the daughter looked at an inauthentic looking will, leaving a vast sum of money to the GP, and her body was exhumed and she was found to have been poisoned. And Dr. Shipman was subsequently arrested and found guilty of her murder. And because of kind of subsequent investigations, it was discovered that Dr. Shipman had murdered 284 victims over a period of about 30 years. I know that's about abuse within the community, but the thing that is most relevant is that the crimes went unnoticed as victims were predominantly female and older. And there was a strong sense in which nobody was looking, that the attitude to old age was such that there wasn't scrutiny or value placed on their lives. And that's just something to think about. Some of our literature, which looks at abuse in care homes, will talk about that wider cultural environment. The other thing to say, which is also talking about the wider environment, is a piece of research that I was involved in. And again, I'm really going to cover it very quickly, so I appreciate it might actually raise more questions than answers, but I think it's important. As you may know, there is a lot of work done around child protection and inequality. So it's called welfare inequality in children's services. So what we've discovered across the UK is that children who live in areas of high deprivation are considerably more likely to be subject to abuse. I suppose you would say, well, that's not surprising, given the impact of poverty on families. But a colleague and I and a PhD student looked at the same phenomenon in terms of welfare inequality and adult safeguarding in the community. And unsurprisingly, we find that individuals living in areas of high deprivation were considerably more likely to have all types of abuse. And also importantly, social workers responded to that abuse differently than they did for individuals who lived in areas of low deprivation. And so we decided to apply the same methodology to looking at care homes. This is just a slide which shows the positioning or the location of our residential and nursing homes in Northern Ireland linked to areas of deprivation. So number one there is an area of the highest deprivation in Northern Ireland. We divide it into 10 kind of factors, and number 10 is an area of low deprivation. And what we find is that to a large extent, residential and nursing homes are more likely to be built or opened in areas of low deprivation. However, there is more likely, considerably and significantly more likely to be abuse identified in those homes in areas of high deprivation. So I hope that makes sense. So if you live in a care home, nursing home or care home in an area of high deprivation, you are more likely to be subject to abuse. The figures there are 2015, 2017. I do have figures for 2018 to 2021. But I think what is perhaps more important is that those lines show, the blue line shows our referral, the grey line shows the adult safeguarding plan, and the orange line shows adult safeguarding investigation. So let me just explain that. The gaps between those lines are important. They show that if you live in a home in an area of high deprivation, you are less likely to have an adult safeguarding referral processed. You're less likely to have it investigated and an adult safeguarding protection plan developed. So that's just really explaining what I've said. If you live in a care home with higher levels of deprivation, you're more likely to be subject to referral, and that referral will be or may be treated differently to those people who live in homes in areas of low deprivation. And it's just, I suppose, highlighting that it's not just what's happening within the home that is significant. There are wider external features. So thank you for listening to all of those risk factors. As I say, many of them will be familiar to you. It maybe paints a bleak picture. I don't know. I'm going to finish, I suppose, with looking at some of the inquiry reports and professional guidance and research literature that talks about what is best practice. Again, I suppose arguably it's the opposite of the risks and managing the risks, but let me identify that. Again, I don't suspect that there will be much that is unfamiliar to you here. Person-centered care, residents, service users being listened to and believed, having ownership of decisions, the engagement with service users and giving them respect and working collaboratively with them is a key feature in terms of best practice within institutional care. Better use of appeals and advocacy services, particularly engagement with family. They need to simplify the process of raising concerns. So Brigitte's study interviewed families of individuals with learning disability who had been through a safeguarding process where their family member was in a residential home, and they talked about the great difficulties they had in engaging in that process, and the need to simplify that and to build. The need to attend to relationships with families was really important. Regular visits and scrutiny from individuals outside agencies and staff training and support. I've taken this slide from Sarah Donnelly, so thank you, Sarah, for it. Bowers looks at safe way models. Basically, this author is considering care within psychiatric units and managing aggressive behaviour and trying to ameliorate that, and describes, I think, 10 potentially effective interventions. And some of these are generalizable, I think. Development of standards of behaviour that have been mutually agreed upon by and for staff and patients, really important, that sense of collaboration. I know that that is a key theme in our residential homes for children and young people, which is about engaging with them early about the potential risk of escalation and agreeing among themselves how that will be managed. Frequently updating guidance on handling flashpoints, training and support on de-escalation, sharing appropriate personal information between staff and patients. So again, in our homes for children and young people, there is a couple of schemes where staff and young people have a kind of profile that they share about each other, getting to know each other, and that's written up. And within that, there is discussion about how should we handle a situation where, you know, the young person has escalated aggressive behaviour. Gooding writes, completed a scoping review for the WHO in terms of good practice in coercive control in mental health settings. And again, I think much of this can be transferable. The really important thing that Gooding says, I think, is that he reviews, or they review, a number of initiatives to try and manage situations without coercive control. And they conclude that top-down and local level leadership was really key in helping to create and maintain practices that limit coercion. So I think they conclude that regardless of the type, the very fact that people were looking at this together made a big positive difference. And I've identified, because of time, I'm not going to go through them, but I've identified some of the key examples that they give. Another feature of good practice is around how we, I suppose it's around governance, but it's about data and evidence. Need the right data and information to provide early alerts. Staff need to measure what happens, but not just focus on where things go wrong, but what is needed for things to go right. Absolutely central is the patient care and staff voice together, freeing up time to care. So the burden on staff in terms of managing admin. In Northern Ireland, we have a project with social workers where we say that 80% of social workers' time is spent on taking notes and recording, managing admin. So frontline staff described a situation where they had to enter data multiple times into multiple systems, and I'm sure that resonates. And then some other research would say we've got plenty of data, we just need to think very carefully about what we do with it. And I suppose that was for us important in terms of the welfare inequality system. All that data is there in terms of the patterns of abuse across the country and linking those with deprivation, but somebody just needed to look at it. Just very quickly, what does good care look like? I'm really referring to some of the material that you have yourselves. So the report that I read in terms of supporting ageing in place, policy integration and nursing home care, really interesting, and lots of good kind of guidance and recommendations around promoting good care. A paper that's referenced in that document, which again is very helpful, looks at human rights of residents in the nursing home sector and will pick up examples of good care in that. I've just given you a kind of resource here, or a list of resources that you might want to refer to. So the United Nations have a database of promising interventions to prevent and respond to abuse of older people, really helpful. Some of it relates to residential care, some of it relates to care in the community. NICE and SCI, so the National Institute for Clinical Excellence and the Social Care Institute for Clinical Excellence, has a whole range of resources around good care within institutions. There is, Marsland has developed a checklist is too simple, but kind of pro forma that agencies can use themselves to monitor the level of care that they provide and to look at risk. And I think it's a really useful tool. And then I've mentioned a couple of authors. Amanda Phelan, who I'm sure you're all very aware of, has done a lot of work in this area. And I've just picked one of her publications there that's very helpful in terms of detecting abuse, current perspectives. And then the paper by Hurt that I've talked about is helpful. And I suppose finally then, I'm not sure what the Irish model is, and I'm sorry that I haven't been able to find that, but there is a lot of professional guidance, really helpful professional guidance around good care within institutions and managing safeguarding issues that are issued by professional bodies, possibly social work, although we don't have one at the minute in the north, but psychiatry, nursing, OT, for example, really helpful. Most of them are saying the same things, and they're the things that I've picked up earlier. Now, I've only a few minutes left, so I just want to highlight a couple of key points for discussion, whether that's now or for yourselves at a later time. Abuse, to a large extent, is defined by professionals, and the responses to abuse are shaped by professionals. And older people, for example, but people, I've done a study looking at people with learning disabilities and their say in shaping adult safeguarding and how they're treated in that context. There has to be a sense in which those people who are the victims or subject to abuse has a say in how it is defined and understood and managed. When we look at thresholds, I suppose it is difficult, I think, within institutional care of working out what is a threshold for abuse and balancing autonomy and protection. So how much individual autonomy are people encouraged to take, and how do we balance that with the need to protect, is really important. And the balance of that has changed over the years. It's definitely changed over the years when I've been in practice, and we're much more focused on people's right to self-determination. And that needs to be taken into account in terms of thinking about institutional care. There is an interesting report by Biggs and Hapala who look at saying we have to be careful that the scope to interpret a wide spectrum of events as instances of mistreatment may render the term meaningless. So I don't want to belie the difficult experiences that people have, but it's trying to get a sense of what is the threshold for those experiences that trigger a safeguarding referral. And as I say, Hurt talked about the literature. It's so poorly defined that the literature talks about prevalence of abuse from 0 to 93%. Okay, nearly finished. Just the important thing, and I'm just repeating what I've said earlier, but the outcome of many of the inquiries has said that we tend to say, how can we as staff make sure that this doesn't happen again? And Marston makes the point that actually we should be very much saying, how can policymakers, practitioners, commissioners, regulators, providers of care enable individuals and their families to safeguard themselves and their loved ones more effectively? So it's very much that collaborative approach. In terms of legislative reform, I know that, like Northern Ireland, you're in the process of that. It's just important to think about the role of legislation and the degree to which that will safeguard individuals. The important thing about legislation is it helps to clarify roles and responsibilities which are nebulous at the minute. It will help to define abuse, define the threshold for abuse, and stipulate the human right requirements, because they're so subjective. Certainly in the north, yeah, there is a requirement for safeguarding adult boards that are statutory and have statutory responsibility, which our policies don't provide that level of statutory engagement. It mandates safeguard inquiries when abuse is suspected, and it mandates multi-agency collaboration. So those are the key features that we feel that our legislation will provide, which we don't have in policy. And then very quickly, summary. So whilst procedures, guidance and tools have been developed, a study in Australia, for example, said it hasn't really made much difference. So they've not been systematically implemented and failed to transform the wider organisational foundations. When we think about abuse, we want to think not just about the dyad between perpetrator and victim, but what are the wider structural and organisational features that contribute to that. As I've just said, you know, trying to change the focus, not just how can we keep people safe, but how can we work collaboratively to enable people and their families to contribute to that discussion. Need for a national policy and legislation. And then my last point, which I focus on with the welfare inequality, is that it's the need for data. A big picture data around what is happening, where and why should precede the development of any policy or legislation. Okay, folks, that is me finished. Thank you for listening. I'll stop sharing my screen now.
Lorna, thank you so much. That was so interesting and so concise and very thought-provoking as well. So thank you. I am going to invite Amanda Casey to reflect in a moment, but just before we do, we've had some great feedback in the chat box. But Lorna, some people are asking if your slides would be available to share afterwards.
Yes, of course. Yes, that's fine.
Thank you very much. Okay, Amanda, it gives me great pleasure to ask you to reflect on the presentation and the issues that have been raised. So thanks, Amanda.
Great, thanks a million, Sarah. I'm just not sure how you follow Lorna, to be honest with you. So I'm going to give a rough go at here for the next few minutes. And I have been sort of writing furiously, so I'm going to try and sort of, I suppose, summarise some of my own takeaways from your presentation. And hopefully then we can encourage some discussion and conversation with the others on the webinar. I suppose, first of all, my first comment is really how completely heartening it is to see how many people have actually kind of joined today. I appreciate that people are extremely busy and under pressure in relation to their work. So to take the time out to join the webinar today, certainly to me is reflective of the interest within you know, kind of healthcare professionals and others to really try and continue to improve the care that we provide and the services that we deliver for people who need them. So I certainly am very kind of heartened by that, and I do see it as a kind of a collective desire to continue to promote people's rights within our care. Certainly for me, in my role as the Chief Social Worker, as I said, I take it as a very positive sense that people are ready for change and are open to change, and I'm certainly very happy to see that. Again, just to echo Sarah, Lorna, I want to thank you for your generosity in sharing your work and your experience and expertise with us. It was excellent. As I said, I've been furiously scribbling here and we'll certainly listen back because I think there's probably so much to reflect on for ourselves.
Thank you.
I think, you know, when you describe, and at the beginning there, you were talking about like that, and I liked your description there where your responses previously in practice where, you know, if there was more than one kind of individual referral in relation to you know, a particular setting, that was kind of seen as a systemic issue and responded to in an institutional way. And I think that's a really positive way of looking at it, because it gives a sense of yes, the individual experience is really, really important, but it is potentially indicative of something kind of broader that needs a very different response. So I think that's a kind of a really helpful thing for me to sort of try and absorb into my thinking. But I think sometimes as well, when we talk about something being a systemic problem or a systemic issue, it can feel quite overwhelming. And in some ways, it can feel disempowering because people feel it's too big for me to fix, it's too big for me to address. And I think that is a challenge for all of us. I think the other thing that really kind of struck me was just the when you talked about the findings from the LE hospital or the hospital in 1967 and the recommendations, and you know, it's difficult not to be disheartened when you see that those things being identified, called out and recommended back then, and findings from recent studies, you know, are kind of telling us the same thing. And you know, anybody, I'm sure, on this webinar, I don't need to say that, you know, we have a poor history in Ireland of supporting the rights of people across many settings, and protecting them from harm. And I think, like that, when you talk about these things, we can sometimes try and explain them away by saying it was a different time or with different culture, but we don't have that excuse in terms of the recent kind of scandals and issues that have come up. And I think, you know, whilst rightfully some of them will kind of grab public attention, albeit fleetingly sometimes, you know, and can force change, which is absolutely needed. I think we always have to be careful that we're not just kind of reactive, that we're jumping to a quick fix, that we really need to look at and consider those underlying kind of cultural issues that led to the situation where those abuses were able to happen. And secondly, I think, as you mentioned as well, that, you know, the major scandal doesn't distract the need to be vigilant about the minor infringements that happen every day. And because if they are left unchecked, they can then lead to an acceptance of poor practice. And I think you had kind of described that, where even the service users or residents themselves had become sort of tolerant of poor practice because it was seen as just that's the way things are here. And again, that leads to an environment where abusive practice just becomes the norm. And I think, you know, like that, it's those minor infringements that maybe sometimes do get overlooked. You know, things like, you know, putting people to bed at 4 o'clock because there isn't enough staff on in the evening to actually kind of do that in a way that is meaningful for the individual residents. Like, you know, people's access to their money or to cigarettes is limited because of kind of, you know, organizational issues rather than what the individual may need themselves. And like assuming that it doesn't matter if people get to wear their own clothes or whether they get to wear clothes they're just kind of around the place and clean. Or what they all have to kind of watch on TV. And again, I've kind of used this analogy before. They're kind of like little paper cuts. And in isolation, they may seem like harmless interactions or interventions, but if they're left unchecked, they then become normalized. And I think those are the kind of environments then where abuse and poor practice is tolerated and less likely to be called out. And it's really only when those paper cuts kind of come together and cannot be ignored any longer that sometimes we respond. You know, and again, you mentioned there is sadly a very long list of names like Dunmurray, like Muckamore, Brandon, Oris, Attracta, Lees, Cross, our more recent kind of primetime investigates. And I think, you know, these names are all familiar to us. It's really important, I suppose, that you know, we don't forget that there are real people and real harm has been caused, and we really, really need to sort of ensure that we don't walk away when the initial attention has gone. We've maybe done the initial reviews, whatever it is. It's about sustaining that. And I'm really struck by the references you made as well to around the kind of importance of culture. Because I think, you know, governance is one thing, leadership is obviously key, but those things and the external regulators and the external checks, they're not there 95% of the time. We will continue to be reliant on, you know, kind of the people who are providing care on a day-to-day basis to actually develop and support a culture that is respectful of individuals' rights. And I think that's a tricky thing. It takes a long time to get that culture right, but unfortunately, as we've seen, it does take a huge amount of time for that to kind of deteriorate to a point at which, you know, that suddenly again we're back into that space where poor care is acceptable. And I think, you know, that good safeguarding culture for me really means that we're all open to learning from when things go wrong and to share that learning with others. And I think that's why I'm particularly grateful for you coming and sharing your experience today. I think it means that we don't tolerate those minor infringements on rights, as they can lead to an acceptance of poor practice. And I think the key to this, and as I said, while I'm so heartened by the attendance today, is you know, leadership and a willingness by all of us to ensure that a clear and consistent message is given to our staff, our colleagues, whoever it might be, that abuse and harm won't be tolerated. Now, I say it as if that's really easy. It's obviously not, because if it was, we would have done it by now. But I think, you know, the kind of that issue around the how do we ensure that those individual rights can be promoted, and how do we ensure that those environments that you described kind of later on in the presentation, where we are supporting and encouraging access to, you know, to advocacy, to external, you know, kind of pairs of eyes on residents and people who want it. And I think those are the things that we really need to kind of concentrate and work hard on. I think the thresholds piece also really struck me, and this is something that we absolutely need to do some more work on here. And I suppose part of my role within the reform programme for adult safeguarding is looking at some of those issues as we develop our new policy and our new procedures, because I think, as you rightly referenced there, sometimes thresholds can make everything meaningless because we kind of lost sight of kind of what's going on. I'm also kind of conscious that thresholds can be used as a barrier, and can very much be seen as, oh no, it doesn't meet my thresholds, therefore it's not my responsibility. And I think, again, harm and abuse is often, as you rightly mentioned, it's in the eye of the beholder, it's the experience of the individual, as to whether they feel that they were harmed by an interaction. I think you are slightly ahead of us in the north, but we are, as you say, both going through a process of developing policies and legislation around protecting adults who may be at risk of harm. But again, I suppose I'll finish on the point by saying that sort of policy and legislation are really important, but they are, I suppose they are only as good as the people who are supporting and making sure that they are alive and that they are meaningful. So, and I think that's where the kind of the culture piece, again, I'll come back to it again, is so important, because otherwise they just become another piece of paper on the wall or a poster in our residence centre or whatever it might be. So it's really about the kind of making them come alive by promoting rights and by actually being very mindful of all of the interactions that we have with people who are being cared for by us. So I think that was all of my notes that I was writing down here. I think I was also struck, and I think someone else has put a question in there, so hopefully you'll be able to come back to it, was just about the different responses from professionals depending on that sort of deprivation index piece. And I was really interested, and it really struck me, and not just about that particular thing, but just about the importance for me as a social worker, but I think as all healthcare professionals, that we are reflective and mindful of our perhaps unconscious bias in terms of our practice and how we respond to concerns around abuse or harm. So that was another take home for me. Thank you.
Thanks, Amanda. That's lovely. Thank you.
Thanks so much, Amanda. It shares an awful lot of what I was thinking as I was listening to Lorna, so thanks very much for that. I'd like to invite Sarah. Sarah's come online as well for our panel discussion. Before we do, and I'll put some questions for you, Siobhan, I can see you've got your hand raised. If you have a question, it needs to go in the chat box. I wouldn't be able to manage 380 hands raised, I'm afraid, so if you wouldn't mind putting any question you have for us in the chat box. And just to say, in terms of guidance documents, Lorna, you mentioned specific guidance that has been developed across different services and disciplines. We have developed a number of guidance tools and a Making Safeguarding a personal toolkit. I'm going to ask Colleen to put the address in the chat box of how you can contact the National Safeguarding Office, but also our pages on the HSE where these tools can be found. So I have some questions and I have some areas for discussion, but just to say the feedback has mostly been to thank us, and thank you, Lorna, for a really excellent presentation. So thank you for that. There's one question that's come in I can probably deal with myself, actually, so I'll take that first. It's saying, regarding the point about also helping individuals to safeguard themselves, in the context of peer-to-peer abuse, can you signpost to resources to use with residents in residential mental health settings to raise awareness? So just to say this, our email has just come in there. Thanks, Colleen. And we do have some tools that could be used in mental health settings as well as across our own services in disability and older persons. But if anybody, if the panelists have any further information, that's fine. We'll get that to you in the chat box. So I am going to actually ask Amanda We have a question: what recourse do families have when family members are excluded from the care of their loved ones in institutions run by the HSE? So as myself and Amanda work in the HSE, it's only fair that we deal with that question. I have to say from the outset, we could only be very general in a response to that. It would very much depend on the individual circumstances. But I wonder, Amanda, have you any general advice for a person who feels the families have no recourse?
Yes, I mean, look, again, I would certainly very much recognise the importance of family and other loved ones and carers and a support network in the lives of people who are living within residential care or kind of care that is being provided by the HSE. And so I think in the first place, I think the general policy would be to include family and other carers as much as possible, and that as is right. I think certainly during our kind of recent history in relation to COVID, we saw obviously from a public health point of view, there was a complete change around in terms of kind of access for family members and care and loved ones to people who were living in residential settings, which obviously had hugely detrimental impact in terms of mental health and quality of life for residents. And we know that there sadly were many situations where family members weren't be able to be there, when their loved one was dying. And I would certainly, hope that something like that, that we won't ever get to a COVID point again, but certainly that we have learned from that to ensure and that we, kind of continue to recognise the importance of family members in the lives of those who are within residential settings, and that is supported as much as possible. I think again, as Sarah said, I can't comment because I don't know what the individual circumstances are. But I certainly think that the HSE has a very clear policy in relation to complaints. And I think, if there is an issue that cannot be resolved locally within the service themselves with the person in charge or the director of nursing, that obviously all of our services are now within regional structures, and there are complaints mechanisms both within that regional structure and also then at national if it can't be resolved locally. So I would encourage people to use those structures if they are unhappy with the level of engagement that they're getting from any service provider.
Thanks, Amanda. Okay, I have a really quick one, I think, Lorna, for yourself. So we'll take that before we get into the more discussion type questions. And that is on really interesting points raised, especially individuals safeguarding themselves. Any current data on sexual abuse in residential care in Northern Ireland? So Lorna, I wonder, could you address that one?
I don't think there is data. So when we looked at the welfare, I should say that keeping records in Northern Ireland and looking at the overview of statistics has not been good. And that individuals, I was part of a working group that's looking at that. So we have not been good at keeping our stats about the amount of abuse and the type of abuse. So what we have looked at ourselves in the welfare inequality study was the numbers of referrals, but those were not broken down in terms of sexual abuse. So apologies, we just don't have that detail.
Thanks very much, Lorna. No, that's absolutely fine. And we certainly wouldn't have the details, so that's why I would have had to have come to you. I'm going to go to a more of a discussion type question now, and I'd actually like all of you to join in, but I might start, Sarah, with yourself. This question has been put, excellent presentation, and really reflects a lot of our experiences as an advocacy service. This is from the National Advocacy Service, who work in institutional settings. There are sadly still over 2,000 people living in congregated settings, institutions in Ireland. Unlearned lessons is certainly a problem, with a lack of learning and poor progress on change and progress in moving to a community-based model. Do you have any thoughts on how that cycle of unlearned lessons can be broken to see a greater focus to build momentum on the closure of institutions? We have the policies, the research, the evidence, but we don't have strong government commitment or necessary resources to get on with closing our institutions. So Sarah, I wonder if you have any thoughts on that very meaty question.
Joanne, that's a fantastic question, but one that is very, very difficult to answer. I think there's several components to it. I mean, firstly, absolutely, we need to be moving to a model of aging in place, more community-based living, the closure of institutions. But I mean, I would have a word of caution in that, and again, I was on a webinar with Professor Des O'Neill recently, and I mean, I think we have to accept that we will always need nursing homes, we will always need institutions of some description, but it's what they look like and what the funding model is. For me, I think fundamental to this question and to this issue is how we as a society view older people, view people who are vulnerable, view people who require care. And it really requires a societal shift. And as you said, Joanne, we need that buy-in from our policymakers and our government to enable that to happen. But again, that there are complicating factors there in terms of our profit-driven model. Which is our primary source of nursing home residential care here in Ireland. For me, there will always be a significant tension between profit margins and high quality person-centered care. So I think, as a society, we really need to look at what models of care do we want to progress going forward? What do we want nursing home care really to look like? But we also need, I suppose, we need here in the Republic, we need our legislative entitlement to home care. We need people to have I suppose the assessments, disability assessments to be fulfilled. Like there's an issue, obviously, as everyone is aware of, how we resource and support people to live safely in the community. But we also, I suppose, the whole issue of housing and supported housing, I think, is also relevant. So look, I've only touched on some of the issues. I'm sure Amanda and Lorna will have other things to add in, but it's a very, very complex issue. But as I said, I think it needs a multi-departmental, cross-departmental approach really to address this in the long term.
Thanks, Sarah. So either Lorna or Amanda, if either of you'd like to. Lorna, do you want to shed any or share any views on that?
Yeah, I suppose so thank you, Sarah. I think you answered that very well. In terms of the North, the human rights guidance around everyone being entitled to private family life really changed how we viewed a lot of the care that we provided in supported housing and institutions. And there was a move really in the last 20 years to close big institutions basically and move people again from large supported housing to much smaller, intimate family type environments. That has not been entirely straightforward or easy. And because of the continuing risks in Muckamore Abbey Hospital, a decision was made, I'm going to say about a year ago, to close that completely. But it has been difficult finding alternative, suitable, supported housing for people in the community. And there is a bit of debate about whether there should still be small, secure units for individuals with particular needs. But yes, Sarah, I mean, I agree with you. It's about societal shift. It's about legislational change. It's about people's entitlement to home-based support and care, their legal entitlement and the money to follow that. And it has to be a multi-agency approach.
Thanks very much. Amanda, do you have anything you'd like to add?
Yeah, no, I mean, I think, look, you've both covered the key points there. And as you say, Sarah, this is kind of a much broader challenge because it is dependent on so many other sort of moving parts. I think the one thing I would say, and I'm noting kind of Anne Feely's comment there in relation to the experiences of decongregation, and something that really struck me from a number of months ago, I think it was Dermot from Inclusion Ireland that talked about sort of, an institution is not just a building, it's a way of thinking. And I think we need to be careful that in decongregating from institutional settings, that we're not just kind of creating more institutional settings but in smaller houses or smaller structures, because really it is about choice. And I think that's the piece that the biggest safeguard is if an individual has choice to choose where they want to live and how they want to live, and that is one of the big protective factors, I guess. So that would really be the piece I'd like to add about that.
Thanks very much, Amanda. We've had a few questions around thresholds and, our scope, I suppose, in our national policy and services outside scope. So we'll come to maybe Amanda and Sarah with them. But Lorna, there's one quick one that I think was in relation to your presentation. It says, can you give an example of how the social workers approached cases differently based on area of deprivation?
Yeah, that's a really good question. So we only looked at the stats. I mean, we'd still like to try and proceed with this study to look at reasons for a difference. So basically, in essence, the difference seems to be that in areas of high deprivation, social workers are less likely to proceed through. We have a 6-stage model of kind of referral, screening, investigation, plan, and then outcome, and that social workers are less likely to proceed through that process for individuals living in care homes in areas of high deprivation. And so, for example, things get screened out earlier, or there seems to be a plan put in place without a full investigation. It's those kind of things. We did do focus group discussions with social workers and social work managers to try and kind of begin to explore some reasons for that. It's difficult to know, and we're just guessing, and they're just guessing, I suppose, but it could be that if you live in an area of low deprivation, you may be surrounded by family members that are more likely to advocate on your behalf. They may have more ability to express their views and be taken more seriously than those families in areas of low deprivation. That's one kind of possibility. What we're saying is that when you look at the risk factors, and for example, the risk factors for staff, that it is possible that those are impacted by individuals in low in areas of high deprivation. So maybe staff training, staff support, staff turnover might be greater in areas of high deprivation. So that's kind of one theory that we're looking at. We need to explore that further, but it's a good question.
Thanks, Lorna. And Sarah, I'll ask you about thresholds in a minute. I just want to flag Eilish Hessian, our colleague former of our parish here in the HSE Older Person Services, has said thank you for an excellent webinar and is encouraging us to just keep this on the agenda because she volunteers with a number of community older person services and is seeing a lot of fear and concern. So thank you, Eilish. It's great to have you here. Sarah, we've had some questions around thresholds and I suppose needing a proportionate response to safeguarding concerns. I just wonder what your thoughts would be, particularly because I know you've done an awful lot of look at the literature around the area of thresholds.
Well, I'm not sure I've done that much, Sarah, but I suppose my initial thoughts, look, I think we do need to look at the issue of thresholds. I suppose in terms of our reform here in the Republic, I'd probably go back to, I suppose I'm not so much fixed on thresholds. I go back to some of those earlier points that Lorna made about the importance of us trying to empower older people and their family members to protect themselves a little bit more, because I think that's a real challenge for us. I know it's something that we are starting to address, but I think there's still a lot of work to be done there. In terms of thresholds generally, look, I think that, we have a zero tolerance approach. So again, we really need to look at, I suppose, how that is being implemented, that all referrals are being acted on, but really that we want to really embed that strong preventative approach. I think, and for me, that's kind of critical that we have the resources and the supports to do that. But look, I'm sure Amanda has a lot more. As I said, I'm not as clued into thresholds as some of the other areas, so I'm going to default and to Amanda on this one.
Thanks, Sarah. Amanda.
Thank you, Sarah. Yeah, look at it, as I kind of referenced earlier on, and I was kind of struck, Lorna, by what you said around that sort of that thresholds can sometimes make everything meaningless because it's sort of it either does or it doesn't sort of meet a barrier or a threshold there. And I think sometimes when we talk about thresholds, it's actually relating to who should be involved as opposed to should we be involved at all. And I think that's often a kind of a key question, and I know it can be a source of frustration. Because at the moment, I suppose nationally, I would say we would have to say that there is an inconsistent response in relation to, kind of how things are managed or dealt with. So I think sometimes this relates, and it's another point. I think there's a couple of questions earlier up there in relation to about, kind of thresholds for when a safeguarding team will take on a case or not, as the case may be. And I think, you know, certainly from the review that was done and the recommendations within the Moving Forward report, you know, it is very clearly best practice that safeguarding is best done by individuals who are known to the person at risk, because it is obviously easier for that individual to work with someone who they already know and trust and have a relationship with than having someone else kind of coming in to do a specific piece of work and then leave their lives again. So I think I would certainly feel if we look at safeguarding in its broadest sense, as Sarah has referenced there, you know, it's about promoting rights, it's about supporting choice, it's about advocating for environments that enable those choices, you know, and those are the preventative factors, and that when abuse does occur, it's responding in a way that is person-centered and proportionate, and that's where we do our making safeguarding personal tools and how we can use those things. So if we accept that that is the definition, that broad definition of what safeguarding is, then really probably every single person on this call is actually doing work to support people to safeguard themselves. And so the question about who should do it, I think, is less important than how it is done. And I think, you know, we need to sort of look at safeguarding not as something separate to the care that is generally being provided to people using our services. It is actually a central and a core part of what we do with anybody who is using our services. And I think it is really then where if someone is engaged well with the service, with the staff, with a team, then obviously that team is best placed to support the person through whatever the issue may be, and to provide supports, supported by a safeguarding team when it is required. And obviously there will be cases, whether it's around an institutional response or whether it's around sort of, you know, serious cases there, where it is more appropriate for an external, you know, team to sort of to take a lead on it. So I think it's going to be very, very difficult. And I guess I am loath to sort of draw a line somewhere that says in absolutely every case, this has to be done. And if it meets this threshold, because it just becomes a source of frustration and actually leads to services kind of, you know, coming up against each other, which goes completely against that collaborative approach that we need to take to ensure that people are supported to safeguard themselves, but are also given that extra support when it's needed.
Amanda, I might just come in again. Sorry, Sarah, just to say, now, Lorna, I'm going to kind of put the spotlight on you, but my understanding is this is kind of coming back to the preventative piece, specifically around institutional abuse and nursing home care. Lorna, is it correct, or am I correct in my understanding that in the north of Ireland, all nursing home residents have an allocated social worker, like the same social worker follows them through from kind of pre-admission to settling into the nursing home?
Yeah, so I think 95%, and this might not be current, but around 95% of our residents within nursing and residential homes are funded by the NHS, and they're automatically got a social worker allocated to them. Yeah. But also then the 5% who are privately funded have the choice of having a social worker. But maybe I should say, you know, when I talk about threshold, it's not that I'm saying, and I think Amanda, just agreeing with you here, it's not that I'm saying that, you know, minor violations should be ignored. It's just at what level do we bring this as a safeguarding investigation? And it's just some thought to that. You know, there are other ways of responding to other aspects of care, which is around staff training, developing culture. In Northern Ireland, we had our first policy was 2006. Our first safeguarding policy was 2006. And the phrase in it was that any incident, however minor, should be reported. And so I was in practice at that stage and involved in what we call achieving best evidence interviews with the police. And, you know, I was sitting with police doing criminal investigations with things that were very, very minor. And the problem with that is that often the service user, the older person, didn't want it. It really wasn't the way they wanted to go forward. And also then resources were stretched enormously for the more significant violations and harm and abuse. So it's trying to find a way that responds to everything, but maybe doesn't respond to the other aspects of it. with a safeguarding, with a huge safeguarding investigative approach. If I give just one quick example, I remember being involved in a situation where two older people in a residential facility, one had knocked another one with a walking stick, and whether or not that was intentional or not, but we addressed it as a safeguarding issue, and it did seem to be negative for both victim and perpetrator. There was no winning in that situation, and there would have been another way of managing it. One of the things we look at in the North is family group conferencing. So maybe if an older person, there has been an issue, an allegation of abuse by a family member at a lower level, that we address it through, systemic family discussions rather than the kind of safeguarding agenda and involving kind of the criminal world in that criminal investigation. Yeah.
Thanks very much. So we only have a few minutes left. For the person who was looking at safeguarding cultures and any guidance materials developed around that, and trusting care, if you look at the guidance documents that have been developed by my office, do have a look at them. The link is there. You will find things that will help you in that regard. In terms of the question around nursing numbers or staffing numbers in nursing homes and standardizing the I suppose the ratio of staff, I guess that's really one for HICWA more than our panel. So and there's a lot of questions I can't get to, we don't have time, but what I will do is, following this webinar, I will put, when Colleen is sending out the slides and the recording, I will try and answer a number of questions in a body of email, or signpost people to where you can get the information. Amanda, I think just before I wrap up, is there anything people are asking about scope? Is there any update we can give around where we're at? We're at such a, I suppose, point of change in safeguarding in Ireland, and we've still got a journey to go.
Yes, thanks, Sarah. And just very briefly, I suppose, just to give an update in relation to that. So we are awaiting the imminent publication of the Department of Health policy, which will be the first national policy on adult safeguarding in Ireland. And that will extend the scope of safeguarding across all of everywhere where health and social care is delivered, essentially. So it will extend the scope to the acute hospitals, to mental health, to private nursing homes, and all other areas outside of the existing narrow scope of the policy. So that obviously in and of itself is going to require the HSE as a statutory body to revise its own policy, which we all acknowledge is well overdue at this point. And so the HSE is undertaking a large piece of work and reform programme, which will incorporate the new policy and will also incorporate the recommendations of the McElroy report, and over the coming sort of months and probably years, in relation to how long it takes to sort of embed new policies, new procedures and all of that, so that we will be working on that. And I suppose that's one of the primary focus of my role as the Chief Social Worker over the next number of years. So we are in the early stages of it and hoping to have our first HC implementation group in the next month. And we will continue to that. So it was just, I suppose, if I can provide any sort of reassurance to say that absolutely adult safeguarding remain very high on the agenda. And certainly in terms of myself and my colleagues in the National Safeguarding Office and in other areas within the HSE. And we are very keen to, I suppose, engage with as many stakeholders and partners as possible in the development of a new way of, I suppose, delivering our safeguarding services, and making sure that all staff feel that they are both empowered and also enabled through the appropriate training and supports to actually, kind of carry out their role. Because I think that we talk about safeguarding being everyone's responsibility, and it absolutely is. But that responsibility might look different for different people, and we need to make sure that we are kind of encompassing everybody within that work.
Thank you so much, Amanda. Well, thank you, everyone. Thank you, Lorna, Amanda and Sarah. It's been a fantastic webinar. It's gone really quickly. I'd really like to thank my colleague, Colleen Murphy, who has put this all together today, has been working with us in the background, making sure this is all running smoothly. So thanks, Colleen. Thank you all for attending, and have a lovely weekend.